Correct. See here. All right. So we have one more minute. Just perhaps we should just start. Good morning. I am Dr. Camran Nezhat, founder and president of Worldwide EndoMarch. I would like to welcome you to this session of the endometriosis and involvement of endometriosis with the bowel. Worldwide EndoMarch, since its inception, the goal has been to increase awareness about endometriosis and help young women and their families who have endometriosis, and also as they progress towards their reproductive age, to guide them through the process of their reproduction and then menopause. Since in its inception, Worldwide EndoMarch has brought attention to endometriosis across the globe. Many, many countries are involved, and we would like to thank every one of you for all of your efforts to make this entity a known entity to everyone, as endometriosis is as common as blood pressure and diabetes, if not more. But the awareness has been poor. Still, we see women who go years undiagnosed and suffer with endometriosis. The session today is related to the bowel endometriosis. Endometriosis is a whole body disease. It doesn't only affect the reproductive organs. Actually, after the uterus, tubes, and the ovaries, bowel is the most common site of endometriosis. And many times, many years, and often the diagnosis is mixed with other conditions like irritable bowel syndrome, diverticulitis, colitis, etc. And there are many, many questions in this regard. The symptoms of the bowel endometriosis could be very variable, and thus the co-founders of EndoMarch, Dr. Farr, Dr. Ceana, Dr. Azadeh Nezhat, and Barbara Page, and also all the staff of the headquarters of the Worldwide EndoMarch continuously are trying to find effective ways to increase the knowledge. Tiffany, Zoe, Elisa, and the other members of the Worldwide EndoMarch headquarters have been continuously in contact with you to try to find how we can answer your questions, educate you, and help you to achieve your goal. We have received many, many questions in respect to bowel endometriosis, And we have put together an outstanding panel, a colorectal surgeon with extensive experience dealing with endometriosis, Dr. Marion Schertzer, that has been working with my brother, Dr. Nezhat, and many years ago, myself and my brother, Dr. Farr. She has extensive experience, one of the most experienced surgeons in endometriosis and colorectal surgery. We are very honored to have her to answer many of your questions, address them, despite having issues with her mom. Still, she has been so kind to accept and do this interview to help the question answer them. Another esteemed guest of ours is Dr. Louise from Harvard University. She is an outstanding physician, I know for sure, because she did her training with me. And she has extensive experience, knowledge in every aspect of the treating women. She has a young girl, so she is very interested in endometriosis, and she has been an outstanding an outspoken speaker for women's rights and how to promote the health of women. And it is a pleasure to have her to speak with us. And today also we have included two of our patients that over the years, their story would tell their story, what young girls, women, all through their life go through this process. They would share with you a little bit of their history, their journey with endometriosis. And one of them is Nioma Sadler. Nioma I have known her for many, many years. She is one of the brilliant women. She is the CEO of her own company, and she goes around the world, and she has established traditional medicinal with her husband, Drake, that they have been very supportive of worldwide EndoMarch and promoting the causes of the women's health. She is, if I might say, she has been promoting women's causes across the world in many countries across the globe, like Kazakhstan, Rajasthan, and Guatemala. She travels around the world for philanthropic work and empowering women, also women wages to be equal to men. And she has had a difficult journey with endometriosis. I have known her for years. I thank her very much for being with us and trying to share her story with us. At the same time, there's another patient, Dr. Ceana, Gail Barker, that my brother would speak and he would introduce her later. And so we have a combination of the stories for you to make this useful. We have received a lot of your questions, and you have sent many, many questions. We have tried to summarize them and select those who has been the most common for everybody. I have to mention at the outset that we are not going to specifically answer everybody's question in that regard. We are going to try to generalize it. We are not giving any of the physicians on the panel are not giving any kind of advice how you should be treated. We are just general recommendations, general guidelines. We have also included one of our latest papers, which was published in the most prestigious journal of American Journal of Obstetrics and Gynecology, and these are guidelines how to treat endometriosis of the bowel. That we will share with you. We try to guide you some direction. Questions have come from across the globe, so we have selected some from different parts of the world as well. Saying all of that, once again, I'd like to thank all of you for your attention, for your interest in endometriosis of the bowel. And we start with the story of Nioma Sadler. She would give a short summary, and later, if there was any question coming up for all the observers, then we would address and ask her more. First Nioma, and then Dr. Ceana. Nezhat would say something about Gail Barker, and then after that, we will start with questions from all the participants. Thank you very much, all of you again, and we appreciate it, and stay well. Go ahead, Nioma.
Thank you, Dr. Nezhat. Hi, everyone. It's so wonderful to be here and to be able to share a bit of my story and the journey I've been through. I want to just start by thanking all the Nezhat brothers and all of the many doctors and the team at EndoMarch for all the hard work and dedication to finding more answers and helping women like me to have a better life. So my husband and I are very happy to be staunch supporters of the EndoMarch, and anytime I can raise my voice for this cause, I'm very happy to. And yes, I've had a long journey. I'm 45 years old now, and when I started my cycle when I was 11, this journey began. I did not know what I was dealing with for a very long time. I went to many, many doctors, just similar story to the women, many women you've already heard from. There's nothing wrong with you. This is normal. Really, really, really challenging symptoms from the time I was a little girl, and no answers. So I was very blessed to actually get pregnant when I was 19. And, you know, looking back, you never know really until you look back why things happen. But I was a single mom for 6 years. And if I hadn't gone through with the pregnancy, I would never have gotten pregnant. So my journey after being 19 and a single mom, it took me maybe till I was 27, I think, 26, to find my answers of what I was dealing with, and finding Dr. Nezhat and having my first surgery. And I've had about 8 surgeries since 2003. And this disease is very, very, very invasive, and especially if it's, you know, invading your body, where you have it growing on your bowel and your bladder and the cul-de-sac and all over. So an invasive disease that just took over these organs. And thanks to Dr. Nezhat and his expert hands and tools and approach, the many surgeries I've had have really, really, really helped me to have a much better life. I'll never forget, after the first surgery, I could actually touch my toes when I did yoga. And all my life, was like I couldn't get close to my toes. And so being able to bend over and touch my toes was a huge accomplishment. And just getting all that toxic growth that just takes over your body. So I know I'm one of Dr. Nezhat's most extensive cases. And I also feel like I'm a very good success story. I not only utilize the technology of surgery and, you know, cleaning up all that mess and, you know, toxic growth, but also doing natural remedies and working with Dr. Osias, who, if you guys don't know who she is, she's also a part of this campaign for EndoMarch. Wonderful woman. She just helped me so much with hormone balance and, you know, supplements and diet and exercise. And I just can't say enough how much that helps to carry this disease. So you got to be really proactive and loving to your body and every way you can, not just the surgery and drugs, but everything you can, from what you eat to, you know, what you think even. So positive thought and, you know, really goes a long way. And for me, my work with women and helping women around the world really keeps me going, because I have a mission that's bigger than myself. So I deal with chronic pain every day. I just had surgery a little over a month ago. And luckily this time I put it off for 4 years. So before that, it was every 2 years. So there is, you know, hope in the horizon if you are dealing with chronic endo on the bowel and bladder and wherever it might be. As you go through this, you can start to, you know, have less need for surgery. And so I'm very grateful to Dr. Nezhat and your team for always being there for me and helping me find the answers and not telling me I'm crazy when I come to you, you know, last month and say, I'm having this really bad pain and, you know, I should be better, but I'm, you know, it doesn't, this is a very mysterious disease that has a mind of its own. And you just got to keep moving forward and finding the answers for each step. And so I'm just so excited that EndoMarch exists and that Dr. Nezhat, you and your brothers and all the many wonderful doctors are working so hard for women like me to find more answers. And so yeah, my condition was a very extensive. I ended up having severe adenomyosis. I did 2 in vitro sessions once I was older and married. Obviously didn't work. So some, you know, I was very blessed to have my son who's now turning 25 this year. So when I was a 19-year-old single mom.
Thank you so much. I want to let you know the purpose of us asking Nioma to be one of the speakers, because we wanted to see that how a woman who is changing the world on her own right, her and her husband, as I said, they have one of the most successful companies in this country. That is the only company that actually, to my knowledge, the tea company, traditional medicinal, actually I advocated for all of our patients post-operatively that they go through FDA approval. So she is running a very successful company. Also, she has a philanthropist of having an organization and travels all over the world for that person, for that purpose and women's rights. And for years, she was telling, it was somebody with that acumen, that much work, and she is ready to do a lot of work. But earlier, for years, it was said that it is in her head, it is nothing important. They meant well, they had good intentions. The problem is what the eyes don't, what the mind doesn't know, the eyes don't see. That's why we are trying to increase the knowledge, the awareness about endometriosis. And example is one here that, again, with all of her acumen, had to go through all of that. One of the severe cases of bowel endometriosis. Thank you very much, Marion. I will go to Dr. Ceana Nezhat to say what is the story of Gail Barker, and then we will go ahead with question and answers.
Good evening, good morning, and good afternoon to everyone. It is a pleasure to be with you today. I am honored, and it is with really pleasure that Mrs. Gail Barker accepted to our invitation to share her story with us. She is a true fighter in my eye from the beginning. Actually, she realized of her endometriosis. She's a true woman advocate about endometriosis, has been very, very active on sharing her story, talking with people, and even though many things like having children, she would tell you this, her story. She couldn't get it, but she wants to have other people know about it. So I'm not here to tell you who Gail is. I would let her speak, and you would tell by yourself that what a wonderful person is in all aspects. Mrs. Barker, you are muted.
All right. Hello, Dr. Nezhat and everyone. Thank you so much for the opportunity to share with you a small portion of my journey as I learned of my endometriosis. But I would like to say that I'm speaking to everyone from Atlanta, Georgia today, and it's been over 20 years. It's really been quite some time since I had my endometriosis bowel resection that Dr. Nezhat and his team performed on me. I would like to start also by saying that I'm so thankful that I had the experience that I did from Northside Hospital with Dr. Nezhat. You guys gave me what I consider a new lease on life. And as I think about it wholeheartedly, I could get emotional because I had struggled with endometriosis for most of my adult life. And actually, from the time I started my menstrual cycle at age 12. But I thought then the pain that I was suffering from was just normal, you know, that you have this pain once a month and it goes away, only to learn that after I got married, my now ex-husband and I had decided that we wanted to try to have children. At age 25, I went off birth control pills and learned that, oh my God, my body woke up with severe pain, and I went through 5 years of treatment trying to become pregnant, to have a baby. But just, you know, at a high level, I don't want to go into too much detail because it's been a long time and I had quite a journey. I wanted to also, you know, just to share that I had two goals in mind once I learned that I had the endometriosis, and the real reason for all of my pain was to relieve the chronic pain that was debilitating me. My whole life after a certain point, at the 5-year point, was miserable. I mean, all I wanted to do was to take drugs for the pain of the endometriosis. And it was just hard for me, and to try to have a baby. So I experienced a lot of surgeries and multiple procedures, just trying to get to the point of relief and hopefully become pregnant. I even, at one point in time, I had issues with my ovaries and cysts, and I did get a topular pregnancy out of the whole treatment. And then I was eventually introduced to Dr. Nezhat because I was in North Carolina at the time. And at that point, I started having problems with my bowels. I was bleeding when I would have my menstrual cycle in my bowels, and I couldn't figure it out, but I had to plan and prepare for those unexpected times. And in doing so, my gynecologist at that time referred me to Dr. Nezhat, and because he felt he had done all that he could do for me. And once I got introduced to Dr. Nezhat, I came to Atlanta, and he performed a surgery. Then it was painful, but I consider it a wonderful surgery now. And I say painful only because when I woke up, I had only expected to be there like overnight trip. I didn't know I was going to be there for a week, because once they got in and performed the surgery, they realized that I had endometriosis everywhere, and including my bowels. And it explained all of my pain. And really, I become frustrated once I learned, because I thought about all the procedures prior to, and everyone had told me they had hopefully and thought they had fixed my problem, which in actuality they had not. But I went through the procedure, had the bowel resection, and again, it was, I felt great, full of energy at that point in time. And after that, I went through about a couple of years after and decided that, I was feeling good, but I was concerned that the endometriosis could potentially come back. And I was concerned that maybe something like cancer could grow in my body. And I ended up having a hysterectomy. But the great news is, once I relocated to Atlanta, I moved my medical records and started seeing Dr. Nezhat, and he's been treating me ever since. And I thank God for him and his family and what you're doing today to make everyone aware of this horrible disease called endometriosis. Because unless you really have experienced it, and especially the severity of it, you really don't have a clue as to what we go through. And it's because of you and your team that I can say that I feel like I'm a success story with you and all the assistance that you've given me. So thank you for that.
Thank you very much, Gail. You are very kind. We appreciate it. It was very kind of you to share your story. And that exactly brings us to the next step that Dr. Louise King from Harvard, she is going to address. There are many, many questions in respect to endometriosis of how to diagnose it. Is it colonoscopy a good way to do it? How often colonoscopy shows that? If endometriosis involves the bowel, bladder, rectum, and how could we address it? Again, these are all in general. You have to always ask an expert, and one of those experts is Dr. Louise King. Go ahead, Dr. King.
Thank you so much for the invitation to participate today, and thank you to Nioma and Gail for sharing their experience. It's so important to hear from patients in these settings. The question generally is how best to diagnose bowel endometriosis. Colonoscopy is sometimes suggested as a way to diagnose it, but of course the endometriosis that develops on bowel will develop from the outside in. So the deposition of these lesions will occur on the outside of the bowel that's presenting in the abdomen first, and then eventually proceed through the different layers of the bowel and eventually arrive at the mucosal layer. Bowel endometriosis can present with symptoms even before it reaches the mucosal layer, including bleeding just from irritation and inflammation. So if you rely solely on colonoscopy to try to assess if a patient has endometriosis, you're likely to miss something. Not all endometriosis that is symptomatic a problem for patients and should be resected is going to proceed all the way through into the mucosa and be visible with the scope in colonoscopy that's coming up into the bowel lumen. Some imaging modalities can show endometriosis on the bowel, but it's dependent on the skill of the technicians who are doing those images for you, and also dependent on the radiology team and their experience in detecting endometriosis. So some really advanced ultrasound teams can detect endometriosis using a combination of transvaginal and transrectal ultrasound, but those are very few and far between. MRI can sometimes, again, show bowel endometriosis, but it depends on the radiology team and whether they're really well trained and well versed in identifying it to truly pick it up. So with any patient that is presenting to us at our clinics with any kind of GI symptoms whatsoever, and not just blood in their stool, but difficulty passing stool, IBS type picture, pain with passing the stool, or dyschezia, which is the fancy name we give it, we should be thinking about bowel endometriosis as a possibility, regardless of what we've seen on any imaging, whether that be ultrasound or MRI, and have a plan in place for what we want to do with it if we move forward with surgery and identify it at that time.
Thank you very much, Dr. King. And the next question is for Dr. Marion Schertzer, the colorectal surgeon of esteemed reputation, who has been working with Dr. Ceana, Nezhat, Dr. Azadeh, Nezhat, and myself, and Dr. Farr, Nezhat for years. And she has extensive experience about the endometriosis of the bowel. Would you please, Marion, explain how many different kind of bowel endometriosis there are, and what are your approaches? Which kind of resections do you recommend, and where and how?
Of course. I think the answer to this question has already been partially touched upon, because we've talked about the fact that endometriosis of the bowel often begins at the outside of the colon wall or at the small bowel wall. Let's begin by saying that endometriosis can be anywhere in the abdomen. It can actually even be outside of the abdomen, but it can be on the mesentery of the small bowel, on the outside of the small bowel, and often on the colon. The outside of the bowel will usually be on the sigmoid colon, on the rectum, or in the space between the colon and the vagina, or the rectum and the vagina, called the rectovaginal septum. If we have implants that are only on the outside of the colon wall, then often we can shave those implants off. And if they're even just slightly deeper, then we can excise that lesion without going full thickness into the bowel wall or having to resect the entire bowel wall, doing a little disc excision, removing a layer of the bowel wall and then closing it. If, however, the involvement of the bowel is more extensive, i.e. it extends inside significantly in terms of more than a very small surface of the lumen, or actually obstructs the bowel wall, which can happen in the sigmoid, in the small bowel, often even mimicking a cancer, then that lesion at that area will need to be resected. So I think it requires expertise, experience in understanding the depth of penetration to understand how we can best relieve the symptom of the patient.
Thank you very much, Dr. Schertzer. The next question is for Dr. Farr, Nezhat, and in general, the question is, if a patient, like in this specific patient, that some of the 2 or 3 patients, they were like this, so we have mixed it up. Again, you have to have obviously be examined by a physician before they can give opinion for sure. But in this case, this patient has had surgery in 2011. She had the endometriosis has been excised, and also she had a hysterectomy. Then she had in 2014 an MRI that showed that she had endometriosis of the bowel, and she had surgery, and she has had some symptom relief, but now she has had severe constipation, diarrhea, distended abdomen, rectal pain, pain with bowel movement. Symptoms are getting worse. Patient like that, she says she has had bowel surgery before. Is it possible that she has had recurrence? How would you approach that? And the question would be answered by Dr. Farr.
Hello, it is a pleasure to be here. I just want to quickly clarify a few things as a general things. One is that when we talk about bowel endometriosis, the bowel could be large bowel or a small bowel. And the most common area of the endometriosis is the large bowel in the lower portion, which is called rectum. Then goes higher up, called sigmoid colon. Then appendix also is part of the bowel, and ileocecum, and a small bowel. So symptoms of the bowel endometriosis depends to which part of the bowel. That is one thing that I want to clarify for all the audiences. The second thing is if patient comes to me and says, I have had excisional endometriosis, I just want to clarify this one. Excision could be complete or could be incomplete. Sometimes it is safe to completely excise the endometriosis because the tissue under the lesion, it is safe to remove it, like pelvic sidewall, not close to ureter or other areas. And when it comes to the bowel, as Dr. Schertzer says, you have to individualize the person. Unfortunately, the bowel endometriosis is very difficult to manage. Overall, endometriosis surgery is difficult to manage. That is the reason that a lot of gynecologists will not touch it. I am an oncologist, I'm a cancer specialist, and sometimes endometriosis surgery is more difficult than cancer surgery. So the role of the expert in endometriosis, especially when it comes to the bowel endometriosis, and have a multidisciplinary group like Dr. Ceana Nezhat, Dr. Camran Nezhat, that they have teams of colorectal surgeon with them, or even myself, in spite of being oncologist, in our team, we have colorectal people to work with the team to evaluate the patient properly. To answer your question, that particular person, as a general, yes, you may still have endometriosis of the bowel, especially if the MRI has shown it. However, that person has to be evaluated, her record has to be evaluated, patient has to be examined to be sure she doesn't have other condition and that mimics the bowel endometriosis. Because you see a lot of patients that they have these symptoms, and when we do a thorough laparoscopy evaluation and they don't have bowel endometriosis, then you have to address the condition different ways. Thank you.
Thank you very much, Dr. Farr Nezhat. Now, Dr. Ceana Nezhat, some questions that have been in respect to all the symptoms of bowel. Is there anything specific? Some questions, some patients that I've had, is there anything related to the pain in the vagina or prolapse of the system? Could it be bowel endometriosis? How would a patient know that she may have bowel endometriosis with the symptom? If you could address that.
In general, if a person listens to the body language and you don't feel right, it is not right. It is not in the head. So if a person has pain with bowel movement, indigestion, feeling pressure in the vagina, changing of the bowel habit at the time of menstruation, ovulation, pain with intercourse, none of these are normal. All need to be evaluated. So bowel endometriosis could be silent to the point that a person, I have had person who came to the emergency room with bowel obstruction, or they had to put a stent on it, and she had no symptom until she had bowel obstruction. Or there are patients who have superficial lesions on the nerve pathway of the pelvis. So feeling rectal pressure similar to the prolapse, it is not uncommon with endometriosis of the pelvis. Pelvis is an area like a cul-de-sac, like a neighborhood. It has all the nerve pathway coming to the bladder, to the vagina, to the cervix, and to the bowel. So it is better to be evaluated.
Thank you, Dr. Ceana Nezhat. The next question is for Dr. Louise King, and the question is, how often this endometriosis could get, like, not only the bowel, could it be bowel and the bladder at the same time, or the symptoms if the endometriosis, as Dr. Farr Nezhat says, endometriosis of the rectum could be near the rectum, it could be on the rectal bulb, it could be higher on the rectal sigmoid colon, goes to a ileocecal and appendix. So, Dr. King, would you differentiate any of these symptoms, or I appreciate if you address that question.
Well, in terms of the actual incidence of each different type of endometriosis, I know that that's been published on, and endometriosis can be present in anywhere between 12 and 40% of female population, depending on what you look at. And similarly, the incidences for each different type can range so widely that sometimes it's not that relevant to think about. But I'd like to pick up on comments made by Dr. Farr Nezhat and Dr. Ceana Nezhat about how bowel endometriosis can be silent and it can present in a variety of different ways, as can endometriosis of all the different aspects of the pelvis and the abdomen. And again, picking up on Dr. Schertzer's comments earlier, it can be found anywhere in the abdominal pelvic cavity or in other areas of the body. The second most common place after abdomen pelvis would probably be the lung. So again, building on what's been said before, if somebody is feeling poorly and can identify their symptoms specifically, there is something wrong. Pinpointing exactly what is going on based solely on symptoms can be exceedingly difficult. Our neural pathways and neural systems are not set up to provide the exact notice of exactly where the problem is. And as I learned in fellowship with you, we had patients who came in with right-sided pain and left-sided pathology. So it's not exactly easy to tell just in the clinic by going through a careful history. The careful history is so important, but I probably won't be able to tell patients exactly where the problem is until I have extensive imaging and have performed the laparoscopy. And even then, the diagnostics can become difficult, as Dr. Farr was just elaborating on, because there can be many contributing factors, musculoskeletal issues that then contribute to the pain, etc. I hope I've answered your question, but if you need further elaboration, just tell me.
Thank you very much, Dr. King. Exactly, you are correct. For the benefit of the audience, we have tried to, again, condense the question, but make sure everybody who has written the question, somehow they are being answered. So there might be repetition, but I think actually that's as a benefit, because it would, they would learn more. And as people join, as we are speaking on the line, and more people are joining, so they would hear it again. And the next question is for Dr. Schertzer. There are some patients, like this patient, who has had bowel endometriosis. She has had surgery by open abdominal surgery by laparotomy. And her symptoms at the very beginning has decreased in general of her pain, but her bowel symptoms have gradually increased. Dr. Schertzer, how would you approach patients like that?
I think it's important for us to realize again that, as Dr. Farr had said, often surgeries are incomplete for several reasons. The main reason being that the area in which the endometriosis was involved in abuts things that are difficult to address, i.e. the ureter, iliac veins, arteries, things that we really cannot sacrifice during surgery, and so we're careful not to. I think most important, we need to make sure that there are not other things going on. Because someone has endometriosis, remembering that endometriosis can mimic almost anything: cancer, irritable bowel syndrome, diverticular disease, colitis. We need to be sure that although they have endometriosis, they don't in fact have another problem. And that certainly can be the case. So we need to evaluate, I think, the rest of the GI tract. What I would generally do is be sure that the small bowel is not causing some of those symptoms with perhaps a CT angiography, and be sure that we rule out the other causes of symptoms that are so similar to endometrial disease. Again, like colitis or diverticular disease or even cancer. These things cannot be simply not thought about because someone carries the diagnosis of endometriosis and has been operated on for it.
Thank you very much, Dr. Schertzer. The next question is for Dr. Azadeh Nezhat, that we have been working together, our niece, for the past decades, and then she would address and answer the question of several patients, including this specific one, that she says she has so much pain with her bowel movement, especially when she has her periods, that she feels she is passing out, and she has to occasionally go, some of them, to the emergency room, or the pain is significant. Can that much pain around the time of menstruation with bowel movement that sometimes is associated with constipation or diarrhea be a sign of endometriosis?
Good morning, everyone. To answer this participant's question, these are the symptoms that are called vasovagal response that could be associated with endometriosis. But the most important thing is it needs to be evaluated. It is a multifactorial. Many other things could cause this vasovagal response, but the severe pain caused by endometriosis especially during the menses, could point out to bowel endometriosis. But it most definitely needs to be evaluated by someone who's familiar with endometriosis and is experienced in treating endometriosis in the bowel and anywhere else.
Thank you very much, Dr. Azadeh and Nezhat. The next question is for Dr. Louise King again, and the question is it possible that you have significant amount of bowel symptoms, like bowel pain, all the symptoms of bloating, indigestion, pain with bowel movement, and have no endometriosis of the bowel and have endometriosis somewhere else?
Yes, that's possible, and I'm sure exceedingly frustrating for patients. It's much easier to have one diagnosis, but as Dr. Schertzer was alluding to earlier, and Dr. Farr also alluded to, there can be other diagnoses at work, and then they can all be playing off of one another. One of the symptoms that you just mentioned was severe bloating, and of course, bloating can occur for a number of different reasons related to prostaglandin release in terms or other inflammatory processes that either originate in the pelvic organs or originate spontaneously within the bowel itself for various reasons. I think celiac's been mentioned, severe IBS has been mentioned, bacterial overgrowth, which we haven't mentioned yet, but can sometimes play a role. And then one of the questions we received when I was reviewing them talked about severe pain with defecation, but no endometriosis seen during surgery or on imaging, and but endometriosis in other spaces. So without knowing every detail about that particular presentation, one hypothesis could be that there's muscular dysfunction within the rectal muscles, not allowing for easy passage of stooling, either as a consequence of or completely spontaneous to the endometriosis. In the same way that a lot of our patients develop pelvic muscle dyssynergia or dysfunction and severe pain in pelvic musculature. So these pictures these clinical pictures become exceedingly complex. The important thing is to form a team between the physician and the patient so that we're working through all the different symptoms and possibilities to get to the answer, but also so it doesn't become overwhelming for our patients, because this can be exceptionally overwhelming where there's not one answer and it gets very confusing.
Thank you, Dr. King. The next question is for Dr. Schertzer. Dr. Marion Schertzer, what is the relationship between indigestion and other symptoms of the GI system in patients who have endometriosis? And how does endometriosis cause problems like bloating and indigestion?
Remembering again, that's a good question. And I think remembering again that endometriosis of the bowel can affect the bowel in many ways and can affect many portions of the bowel. Mostly, let's remember also that just because endometriosis might be on the sigmoid colon doesn't necessarily mean that that pain is going to be in the left lower quadrant. How many times do we go in to operate on the sigmoid colon and the sigmoid colon is sitting on the right side of the abdomen? We're sitting higher on the right side of the abdomen. So remembering that specifically where the endometrial disease might be may not be where the patient feels the pain, because the pathways cross over and because the bowel is mobile. Often as well, endometriosis will involve the small bowel, particularly the mesentery of the small bowel, causing symptoms of partial bowel obstruction and therefore pain after eating, which is quite a common thing to happen. So while we might usually think of as endometrial pain as being pain in the pelvis, it could be pain anywhere throughout the entire abdominal cavity, and particularly after eating.
Thank you very much, Dr. Schertzer. There are many questions again regarding repeat surgery, how to do the surgery, and as we have said it over during the demonstration, every patient needs to be individualized and treated after the examination by a specialist, so we don't give a specific recommendation. But in this, for example, in a case like this, who Dr. Farr would answer, she has had a stage 4 endometriosis, including bowel endometriosis, and in 2015 she has had surgery, and her symptoms are back, and now her physician doesn't want to do any more surgery. Dr. Farr, when should a patient with endometriosis of the bowel have repeat surgery? What are the other options? When should she have resection or not resection? Thank you.
Again, the expert panel explained everything. If you pay attention to what they say, is that the bottom line is that you have to individualize the person. One more thing I want to mention is that, unfortunately, endometriosis, in spite of doing the best surgery, the best surgeon does it, and do excisional endometriosis and eradicate the disease, endometriosis could come back. However, when you deal with endometriosis, because fortunately it is not a cancer disease, it is a quality of life. And then to see what you could do, tailor your treatment that is the most effective one and causes the least side effects and complication. This is a general thing that when I discuss with my patient or when I teach to my fellows. So if the patient has had endometriosis and her physician said, I have done excisional endometriosis and now she has symptoms back. As I said earlier, excision doesn't mean that endometriosis doesn't come back. So we have to evaluate the symptoms. And then, if you are highly suspicious that endometriosis of the bowel has come back, my first approach to see if I could manage it medically. Because if you want to do a complete excision of the bowel endometriosis, you have to do bowel resection. And the bowel resection, unfortunately, could be associated with some complication like infection, bleeding, even nerve damage. So hopefully one day we could find some medication could take care of it, like the same way we are finding new medication for cancer, we could find medication for endometriosis. Right now, we have some medication like GnRH agonists, antagonists, progesterone. I know all of them, they have some side effects, but we have to, in our treatment planning, having this medical treatment available. And if you have symptoms, my first option is to offer them medical treatment and watch the person to see if she responds. If she doesn't, and I'm highly suspicious after all we said, thorough evaluation, colonoscopy, imaging, if I still am suspicious of the persistent endometriosis, discuss it with the patient about the goal, what do I want to achieve, and what is the possible complication, and we make a joint decision to proceed. Thank you.
Thank you, Dr. Farr. Yeah, and that leads me to the next question for Dr. King, that it is almost the same. Again, as I said, a lot of them are repetition, but it is very helpful as people are joining the, and this live stream is going to be online and people would hear it again. Dr. King, there are patients who have had surgery, including bowel resection for endometriosis of the bowel, but their symptoms continue. This patient wants to know if there are any other treatments, including alternatives, herbs, or, for example, physical therapy, or do you recommend anything else?
It'd be difficult to give a recommendation without knowing more specifics, but in general, there are a lot of things we can do. So let's presume, for the sake of argument, that the excisions were adequate and there's no residual endometriosis. I mean, you really do need to know that that's true. You need to have either done the surgery yourself or know the surgeon who's done it, and really feel confident that there's no reason to be going back for another surgery. But assuming that's true, there are still patients with extensive symptoms. And I agree, it's really important that we're repeating all of these topics over and over again, because it is worth saying again that there can be many different processes that are going on. So really sitting down with a patient, thinking really broadly about what different things could be affecting the gastrointestinal system or the urinary tract system, and approaching it from a multitude of different angles. So in my practice, we have a lot of, and I know in many practices, especially in yours, Dr. Nezhat, there are collaborators within Boston and within Palo Alto area, and I'm sure around the country, who know a lot about alternative and complementary medicines. Acupuncture is fantastic. Different really talented pelvic floor therapists can be exceptionally helpful. I know many patients have found pelvic floor therapy frustrating, and like anything, it depends on the talent and skill set of the person that you're working with. But I've seen many patients have great success with that. Changing your diet, being very conscious of your diet and what are your triggers and what inflammatory triggers you might have is very important. And then even we work with some of our patients on mindfulness training. There are many different avenues to pursue. It may be that Nioma has something to add to this as well, given her work in herbal therapeutics, which I don't know as much about, but I partner with people who know quite a great amount about that, both from the Ayurvedic or Indian tradition and then the Chinese tradition. So as far as I'm concerned, when I work with patients, if we find something that's helpful, let's pursue it. And I'm always willing to think very broadly. But I do want to be sure that that initial surgery, that I'm not relying on it incorrectly. I want to know, read the op report, know that something's been done that is adequate treatment surgically.
Thank you, Dr. King. And you are correct. Herbal medicine, they indeed are very helpful at times. We have seen it in some patients. And that is why we have Marion, Nioma Sadler on the line. As I said, we are very lucky to have her because she is the founder of Traditional Medicinal that has been, that is the only herbal medicine, to my knowledge, and Marion can correct me, that I think they have the teas that some of them for the digestive tracts, like a smooth move, etc., that has gone through FDA. And also, of course, with Dr. Joel Osias, one of our physicians here in Palo Alto, who does a lot of alternative treatments. So, Nioma, are you online? Would you like to address the question? You want to add anything?
Well, I think everybody's it has a real individual, everybody is unique in what works and what doesn't. And so what works for me may not work for someone else. And, the smooth move tea, obviously you recommend after surgery, which is very helpful. And it is definitely a laxative medicine. There's so many other teas that traditional medicinals makes. And, a lot of them are for digestion and cold and flu and women's health. So each formula it can be tried. And one of my favorite ones that I drink for relaxation when there's cramping and pain is chamomile lavender. It's a formula with the pharmaceutical grade chamomile and lavender. It's a really lovely tea. I make it very strong. I'll use even 4 bags and drink that down, and it really just calms the whole system and all the cramping for the ball especially. So there's many different kinds of teas to try. And as far as just working with Dr. Osias, it's also a lot of supplements and just what you eat and don't eat. And so trying different things that may be more irritating to your bowel, eliminating foods and trying that and seeing if it helps is really essential. And like I said, everybody's different. So I find my pain is really well managed when I follow the keto anti-inflammatory diet, which obviously is recommended for cancer patients and people with inflammation. Endometriosis and inflammation is one of the things that's the hardest to deal with. And so if, you know, you are what you eat, they say. And so if you can manage what you put into your body, it can also have a significant effect on mitigating your symptoms. So for me, the keto diet, which is, you know, no sugar, no carbs, and, you know, anti-inflammatory it's been a huge success for me personally. So,
Thank you very much. Go
yeah,
ahead, please.
thank
Thank you very much, Nioma. And Dr. Schertzer, there are a lot of patients that they come to you and for years they say you have irritable bowel syndrome or diverticulitis and they end up having endometriosis. What is your experience from in this regard, or how could it, or are there patients that they could have a combination of all of the above, or how do you differentiate between them and how could you manage them?
First, sorry, can you still hear me? Okay. I think it's important, as I touched on before, to recognize that none of these diagnoses are exclusive to each other. So patients who have endometriosis may very well have irritable bowel syndrome, may very well have diverticular disease. They may very well have all three. Endometriosis is the grand mimicker of everything. Often you go into the operating room thinking you're operating on a patient with a cancer because they have a mass that's completely obstructing the small bowel, and the final pathology is endometriosis. So one always must approach the patient with the idea that there may be more than one diagnosis and that you need to treat the patient and not a specific diagnosis. Treat them broadly because we may in fact have more than one thing we're dealing with. So it's always important to work up the possibilities, keep the other possibilities in mind, and never focus singly on any one diagnosis, even in a patient who already has and carries one of those diagnoses.
Thank you very much, Dr. Schertzer. You know, there are several questions from England, and one of them was specifically that, again, Dr. King hopefully would address it, is about diverticular disease, the diagnosis of diverticular disease, endometriosis that Dr. Schertzer just addressed it, and the role of exercise and other remedies for this treatment. And I don't know if Dr. King has any experience in United Kingdom, but this specific patient is asking, is this something doctors in United Kingdom should know about? I don't know if we can address that or not.
Well, we as physicians who specialize in women's health, whether we're in the UK or the US or anywhere in the world, we should know as much as possible. And so, you know, of course, they should know about alternatives. They should know what Dr. Schertzer has reiterated a few times, and I'll repeat again, which is that diagnoses can exist together. So you could, for example, be told that you have diverticular disease when you in fact have endometriosis, or you could have both at the same time. And getting to the bottom of that requires diligence and a multidisciplinary team typically, who is really going to take seriously what you are complaining of and is going to work you up in the appropriate fashion with both imaging and typically surgery. In terms of exercise, for any patient that is suffering from any chronic condition, and endometriosis is a chronic condition, exercise is beneficial. We know that it releases, if you exercise regularly, you release endorphins, which are natural painkillers, and natural anti-inflammatories. So a reasonable, regular exercise regimen will benefit you. And physicians, of course, around the world should know that recommending exercise that is appropriate to you and to your condition would definitely be of benefit. Sometimes patients, though, are in such pain that they can't even get there. And so again, as has been said before, but should be said again, these are all individualized conversations that have to be had with the patient in front of you, meeting them where they are and finding solutions moving forward for what they are currently facing. Sometimes exercise is not an option on the table at that moment, but hopefully something we can work up to.
Thank you very much, Dr. King. We are going to continue. We have some more questions and that we are going to answer them. And we have a lot of people even now joining the stream and they are listening. So we will, it has been already almost an hour that we have been online, but we will try to finish the questions and answers as soon as possible. So I am going to combine some of more of the questions together, and hopefully we can get to them again, because we appreciate you, all of you are watching and joining. Because of that, we will continue the session. Dr. Schertzer, this question for you, that could patients with bowel endometriosis at the time when they have bowel movement also have some discharge from the vagina, like bloody discharge? Is it possible? One, and the other one is also the patient that they have GI symptoms. What are the GI symptoms that they could have with the patient that have bowel endometriosis?
I think they're both good questions. First, they recognize that one of the major places in terms of anatomic position for endometrial disease is always going to be in the pelvis. Again, it could be anywhere, but in the pelvis and specifically in the rectovaginal septum. So if we have disease in the rectovaginal septum during defecation, when a patient is going to the bathroom, they may very well have some drainage and discharge into the vagina, usually blood, basically because of the position in which the endometrial disease is. Other GI symptoms can be, there are many, but specifically because endometrial disease can just be deposits along the mesentery, or can actually completely constrict the lumen of the bowel, symptoms of obstruction can occur. Endometriosis often, just by its nature, is sort of like very fibrotic and very concrete in its nature. And so often patients will just have specific bowel wall pain just because of the pressure of the endometrial deposit on the bowel wall or in the pelvis. So pain, pain after eating, pain during bowel movements, bleeding during bowel movements, those are the usual GI symptoms of endometrial disease.
Thank you very much, Dr. Schertzer. We have had a lot of questions that they have been coming in through the live stream, and I think most of them we have tried, and I have to thank our fellows, Dr. Anupama and Butler, that she has been trying to answer them, and Dr. Asari and Dr. Roman. But there is one that Dr. Ceana, if you could address it, and has been about women who are trying to get pregnant and they have bowel endometriosis. How aggressive should they be in treating the bowel endometriosis? Or what is the role of IVF, or when should it be done? When should the surgery be done? Dr. Ceana, could you please address that one?
Yes, thank you. One thing we have to remember, endometriosis is not just a disease, it's a process. It has different manifestations. It could be inflammatory endometriosis, it could be superficial, it could be fibrotic. So it is an enigmatic disease. A variety of endometriosis could exist and create variety of symptoms. So knowing the fact that we are talking about how to treat endometriosis, we have to know what type of endometriosis it is, and definitely it could cause inflammation. Inflammation could be associated with inflammatory bowel symptoms, etc. As far as the infertility and fertility management endometriosis is concerned, dealing with bowel endometriosis in an infertility patient all depends on the invasion level of the disease. Sometimes during treating endometriosis at the time of surgery, less is more. It means if it comes to the point that we know this endometriosis does not cause bowel obstruction or ureter obstruction, or it's not going to lead to the losing of the organ function, it is okay to leave some of it behind instead of going deep into the bowel and cause infection to damage the tubes, the ovaries, and compromise the fertility. So we published our experience, we call it fertility enhancing endometriosis surgery. And at that time, it is better to stop at one level, letting the patient know that there are some disease are behind. Some of them may regress. About 25% of the time it would regress and wouldn't need any more treatment. Or when they are done with the childbearing and reproduction, and if they have symptoms or if the disease is invasive, then it could be addressed at that time. Thank you.
Thank you, Dr. Ceana. There is another question that Dr. King could address it, that there are patients that have had bowel surgery or endometriosis surgery. The endometriosis has been thoroughly treated, but they continue to have bowel symptoms. How should they address it? Is there any food they can eat that would make it easier? How should they address those continuous discomfort despite surgery, and how often surgery might not be successful?
So bowel endometriosis does frequently recur. The first step for anybody who is addressing this with a patient is going to be ensuring that the surgery was done adequately and that the whatever could be removed was removed. We've discussed in our conversation so far sometimes sometimes surgery for endometriosis might be incomplete. So making sure that we really don't have further lesions that could be removed is the first step. If we're really there and we have a patient who's undergone even multiple surgeries and we really haven't gotten to the bottom of the problem, we might not have done a good enough job of elucidating all the different contributors to this patient's pain picture. And so, as we've said a few times, multiple disease processes and painful diseases can exist at the same time. If somebody's still having significant bloating, for example, which is such a common complaint, but we really feel like we've addressed all the endometriosis lesions that can be addressed, we need to start looking at diet. We need to start looking for potentially small bacteria, small SIBO, I never get the name right, but bacterial overgrowth in the bowel. Celiac disease, controversial, but potentially needs to be ruled out. All of these different things can contribute to bowel disease. And so ensuring that you're part of a team of physicians who are working collaboratively and in trying to come to the end result of a constellation of different conditions that might be contributing to your pain is really important.
Thank you very much, Dr. King. I appreciate it if all the panel, all the physicians on the panel, and also Ms. Barker and also Ms. Sadler, all of them, if they like to give any comments, I appreciate it if you prepare or you go ahead and give your comments. At the same time, there are some other questions that question number 22 that Dr. King, I think you are looking at it. This is from England, and 23 from Dr. Schertzer. If you, and there are a couple of other questions, if you could read it yourself and combine the answers, and we would start with anybody who has to give any comments, would like to give any comment. Dr. Schertzer, would you like to give a comment or read some of those other questions that you think you can address it yourself, or you want anything that you would like to add? We appreciate all the participants that are still online, that are not leaving because they are interested to listen. Thus, we have continued the session. We truly appreciate all the audience. Also, we appreciate all of the panel that they have given outstanding information for our patient. Why don't we start with Dr. Schertzer, if you would like to add and answer some of those questions that it is addressed to you.
All right. I think perhaps maybe not in summary, but to reiterate particularly everything that has been said earlier, and specifically what Dr. Ceana Nezhat has touched upon. Surgery, specifically bowel surgery for endometrial processes, is complicated. It's probably more difficult than cancer operations. It's probably the most complicated and difficult surgical procedures that I do for several reasons. The main reason is that in a lot of cases, when this is not a complete bowel obstruction, we're talking about quality of life. And for quality of life, we need to think about we cannot do more than we should. If we do more than we should, we're probably going to decrease the quality of life for the patients. So prudence on the part of the surgeon, experience on the part of the surgeon is so important if we wish to enhance the quality of the patient's life and not detract from it, meaning do enough and not too much. That's probably number one. Number two, recognizing that bowel symptoms can always be due to a constellation of problems, endometrial processes being one of them. So whenever we're dealing with bowel symptoms, we always have to keep in mind the constellation of problems that bowel diseases in general will provide. And one needs to keep an open mind every time for every patient.
Thank you very much, Dr. Schertzer, for an outstanding opinion. We are very grateful to you. Dr. King, how about yourself?
I also want to thank Dr. Schertzer because that is such important points to bring up, that this is difficult surgery and we don't have any definitive research that proves the exact way forward. So it has to be expert opinion, and it has to be so somebody who really knows what they're doing, and then also working with a patient to determine how their quality of life is affected and how far to go. I read all the questions that were submitted, and one topic that we haven't touched on is a couple of people have mentioned that after hysterectomy, they experienced severe constipation, which I've seen as a complaint of a lot of hysterectomy patients. There are a few things that I do typically when that's the primary complaint in presentation. I like to review the operative report, make sure that the surgeon who did the hysterectomy was looking for endometriosis in the event that it was missed and that's contributing, and perhaps we need to go back and take a look and really establish whether there was a full treatment at the time of hysterectomy. But in addition, a lot of women with endometriosis who undergo hysterectomy, even if they've had good treatment, end up with different bowel patterns afterwards, because many women have prostaglandin release at the time of their menses. And so they have constipation ahead of menses, and then this release or loosened stool with the prostaglandin release at the time of menses. And when that disappears, the constipation gets worse. Understanding that can really help women get control of post-hysterectomy constipation that might occur. So that was just the only thing I think we didn't address in the questions that were raised.
Thank you very much, Dr. King, for your wonderful contribution. For all the participants, Dr. Schertzer is in Atlanta, Georgia. Dr. King is in Harvard University in Boston. And then we have next the question that came up today in the live stream, and this is for Dr. Azadeh Nezhat. And Dr. Azadeh has a lot of experience dealing with teenagers and young women with endometriosis. And one question is for you, Dr. Azadeh Nezhat, that how do you deal with teenager young women when they have severe pain and some of them have endometriosis? What is the best approach for them if they have bowel symptoms?
I think just like any other patients we would do, we try conservative management mainly to try to see if that helps. Teenagers is anywhere from 12, 13-year-olds to the age that they could try other things to see if that relieves their pain, and a lot of these things are specific to their symptoms. So we treat that way. Ultimately, if none of these works, obviously the surgery to treat or exactly diagnose where the symptoms is it related to endometriosis or to rule out any other cause of their pain should be done. And I think that's usually has been our approach. So with any other patients, we do similar things.
Thank you very much. I just mentioned this specifically because this question comes up, and this past week alone, we had, and this is why we have to have an open mind about endometriosis. And endometriosis is an enigmatic disease. This is why, as Dr. Farr has said for many years, hopefully we find a medical treatment for it because it is spread. It is not cancer endometriosis, but sometimes some of the behavior of it, like metastasizing, is like cancer. So we have open mind. We have had recently a very young girl, only 12 years old, that had all over physicians everywhere, and unfortunately has had all kind of workup, and parents were desperate, everybody, and very, very rightfully, all the physicians who had seen her had tried all the conservative approaches, and nobody didn't know, and they finally was referred to us and to our own, not, of course, we haven't been very surprised ourselves, but we found endometriosis, we treated it, and she is a different woman. So what I'm trying to say, we have to have an open mind, and as Dr. King said many times, individualize the care of each patient. Every patient should be properly treated, evaluated by a physician. Dr. Farr, Nezhat, do you have any additional approach advice?
Just want to add one important point for our patients that they have been dealing with this issue for years. When you decide to choose your physician, first do your homework. You should evaluate that physician experience with endometriosis, write down your questions. And when you see that physician and you are concerned about bowel endometriosis, bladder endometriosis, and if she or he is capable to address your questions and your desire, let her or him to operate on you. However, when he operates and he has credential and says you do not have bowel endometriosis, do not pursue it anymore. Because as Dr. Camran just said, endometriosis, and other people said the same thing, endometriosis is the disease of the body and mind. And the women that they have gone through a long time of the suffering and reading the Google, talking to the neighbors, they have all kinds of ideas in their mind. At the end, you have to come to conclusion with yourself that you do not have bowel endometriosis, or you do not have bladder endometriosis, and then focus your issue to something else. Otherwise, you are going to find somebody else to operate on you, or sometimes they remove your ovaries, sometimes they remove your uterus and cause more problems. Thank you.
Thank you very much, Dr. Farr. Dr. Ceana, do you have any comments?
No, I really have enjoyed being part of this. I would like to thank our patients who volunteered their time. I would like to thank all the panelists for their excellent contribution. It is so much said that I just like to sit back and digest it because I learned a lot today. And I'd like to thank all of you for this opportunity.
Thank you also, Dr. Farr. Ms. Barker, do you have anything you would like to add? Any comments you would like to say? Gail, are you online? Would you like to add anything?
Yes, hi. I just want to say that it has been a pleasure to sit in on the seminar today, and thank you so much for the invitation and all that I've heard. I could relate to in some way, shape, or form, and including the recommendations for post bowel resection and what you should take when you want to avoid having constipation. And I would like to just add that for me, probiotics have worked well for me, and it may be something that someone else could use as well. Just a more natural approach for me. But thank you very much. I don't have anything else to add, but it's been a great experience.
We thank you very, very much immensely for your participation, Ms. Parker. Thank you. Nioma, Sadler, do you have any comments, recommendations?
Well, again, I'm just really honored to be a part of this and to be able to, share my story and have the support of all of your team, Dr. Nezhat. And I echo Gail on the probiotics. It's a very important part of the supplements and things that you can take. Our gut is, a big part of our immune system. And so treating this as an autoimmune disease and giving yourself all that autoimmune support is really key. And probiotics is a really big part of that. Thanks for saying that, Gail. I don't think a lot of people realize that. So just got to keep on keeping on and putting one foot in front of the other. And one of my biggest tools I use is trying to have a positive outlook and not let the heaviness of this disease get me down. Just one day at a time kind of approach. And, just hope that there's more answers as we go forward. And, having 1 in 10 women carrying this disease. And we know it's probably more than that because of the limited testing that is available. So I imagine it's more like 1 in 5. But that's obviously not mine to say, but I just hope and pray that we continue to do this work together. All the Nezhat brothers, you guys are all just so amazing. My hat's off to you. I'm just so happy I found you guys, and all the work you do for us women is just extraordinary, and I'm just so grateful.
Thank you very much. You are very, very kind. In general, I wanted to thank all the panel one by one for their immense contribution. I also thank all of you for listening. And please realize that when we started Worldwide EndoMarch, our goal was to raise awareness, find a method to diagnose it without surgery, and find a treatment without surgery and a method to prevent it. That is truly the goal of all these sessions. And we are gradually approaching that. By yard is hard, by inch is a cinch. We are moving little by little, and we already are making an impact. It is because you, as women, you are interested. There are at least 200 million women around the world that have endometriosis. It's very common. In America, at least there are 10 million women with endometriosis. But in America, in the US, we have subspecialists to treat gynecological cancers, and there is a specialty called GYN oncology. And there is only every year in America, less than 100,000 GYN cancer. But there is 10 million women with endometriosis, but there is no specialist for endometriosis. Although Society of Laparoscopic Surgeons has started a fellowship for that area, and American Society of Reproductive Medicine and Society of Reproductive Surgeons have started that process, but it takes a long time. So that is why we get united, understand the problem, and then we hopefully can help women and young girls who are the foundation of each family. There are mothers, there are sisters, and there are wives. So these are the foundation of each family is a woman. So we have to make sure the endometriosis that is so common is treated, because it changes the quality of the life of people. Unfortunately, still, people, they say it is in their head. They think it is in their head. Imagine that 12-year-old girl that we treated her, her life is totally different now, just even within a short period of time. So we need to listen to the patient and we help them. We thank you very, very much again for your attention, and we will see you next month with the next session. Have a great week and the month.
Thank you.
Thank you.
Bye-bye.
Bye-bye. Thank you, everybody.